No one trained you for inbox medicine. You went to medical school to diagnose, to think, to make decisions, to treat patients, and yet today, a large percentage of your clinical work happens in an inbox. Messages about glucose readings, clarifications about medications. Is this number okay? I missed a dose. What should I do? My sugars have been higher this week. None of this happens in the exam room, and almost none of it is acknowledged by the healthcare system as real care. But it is care. Inbox medicine has quietly become one of the most cognitively demanding parts of being a physician, and it's almost entirely invisible. It fragments your day, it pulls you out of focused clinical work, it forces rapid decisions with incomplete context, and it often happens after hours when your brain is already tired. What makes it worse is that inbox medicine is reactive by design. You're not seeing the whole picture. You're seeing pieces, one message, one number, one concern, stripped of trend, timing, and context. So you're constantly asking yourself, is this urgent? Is this noise? Is this a pattern or a one off? Do I need to act now or can this wait? That constant low level decision making is exhausting. And here's the part physicians rarely say out loud: inbox medicine is risky because when care is fragmented into messages, responsibility becomes blurry, but your name is still on the chart. A glucose reading that sat unnoticed, a pattern that wasn't obvious in isolation, a patient who assumed silence meant everything was fine. In hindsight, it's easy for someone to say, why wasn't this addressed sooner? But in real time, it was buried among dozens of other messages, alerts, and administrative tasks. This isn't a failure of attention, it's a failure of system design. We built a care model where continuous physiologic data exists, but physicians are expected to interact with it in a way that's piecemeal, interrupt driven ways. And that's not how humans make good clinical decisions. Good medicine requires context, trend, prior response, follow through. Inbox medicine strips all of that away, and over time, it creates moral fatigue. You know patients need more continuity. You know that chronic diseases don't behave on a quarterly schedule. You know the visit alone isn't enough. But the only tools you're given are messages, alerts, and documentation requirements. So you compensate. You do unpaid work, you carry mental notes, you remember patients long after the chart is closed, and slowly that turns into burnout. And here's the irony: most physicians don't hate care between visits. They hate chaotic between visit care. They hate care that has no structure, no clear owner, that interrupts instead of supports, and leaves them exposed. When between visit care is informal, it leaks into your evenings, your weekends, and your headspace. Now, let's contrast that with a different model. A model where physiologic data is reviewed intentionally, where alerts are triaged before they reach you, where adherence issues are identified early and not weeks later, where patterns are summarized and not dumped into an inbox. In that model, the physician isn't reacting, they're deciding. Instead of answering 10 messages about glucose readings, you're responding to a distilled clinical picture. Instead of wondering what you missed, you know what was seen, what was addressed, and what was escalated. And that's the difference between inbox medicine and structured care. And to be clear, this isn't about adding work. Most clinics are already doing this work informally. They're just doing it without protocols, without staffing, without visibility, and without protection, which is the worst possible combination. Inbox medicine didn't appear because physicians wanted it. It appeared because chronic disease outgrew the visit model and nothing replaced it. So physicians filled the gap themselves. If any of this feels uncomfortably familiar, that's not a coincidence. It's what happens when good clinicians are forced to practice inside a system that doesn't match reality. If you want to understand whether your current setup is quietly turning you into an inbox manager, or what it would look like to structure between visit chronic care in a way that protects your time, your focus, and your license, then there's a link below where you can request a short, no pressure conversation. It's not a sales call, it's just simply a chance to walk through how much care is currently happening in your inbox, what risks that creates, and what a more intentional model could look like in your practice. If it makes sense to go further, we'll say so. And if it doesn't, you'll still leave with clarity. Either way, you shouldn't have to practice medicine one message at a time.